Hello everyone, welcome back to our channel guys. This is Dr. Shubham. Good evening everyone. Rishi Raj, good day, thank you. Marwa, thank you. Himat, good evening sir. Ramshel, hello. Sannyasi Pandit, hello everyone. Please join in fast so that we can start our stream. Hello Fadel, hi. And please let us know, is there any issue with the audio or the video? Sri Krishna, Sai, hello, very good evening. Gray, very good evening. Sannyasi Pandit, yeah, yes sir, I will try to complete. I will try my best. I will try to cover the most important aspects of the trauma basically. Sakala Shombe, sorry for my pronunciation. Uh, Watching from Zambia, thank you so much. Sound is clear, thank you. Okay. Rahul, Rahul Sonavel, okay. Hi, hello, how are you? Audio is heard well, okay, fine, fine. So let's just start in one more minute, okay? Let's SK Bera. Okay, let's start. Okay, yeah, just a minute. Let's start. Abhi, hello. I'm from Ethiopia. Okay, hello from India. Yeah. So guys, during the streaming, okay, in case if you feel any kind of doubt, okay, please feel free to clear your doubt. Okay, I will try to answer at the same time. Okay. Gure watching from Somalia. That's great. Thank you. Hello. Hi Amit. I hope also you are also a doctor if I'm not mistaken. Hello everyone. So we are going to start with the stream now. Okay. Meanwhile, others will join as well. So today I am guys, first of all, let me introduce myself. I am Dr. Shubham and today I am starting with the surgery session. And the topic which I took for today's class is the trauma. And trauma is a very important topic. You might have, you might had your postings in casualty or in the orthopedics or in the surgery department. You might have come across these kind of cases, that is trauma, right? Now you might have come across the head trauma patients or the abdominal trauma patient, thoracic trauma patients. So these are very common, and from the MCQ point of view also it is tremendously important because very wide topic and a very important one, and very commonly it is tested clinically as well as theoretically also, right? So we're going to start with the trauma now. So with the trauma, first of all I will try to clear some basics. Okay, we'll try to discuss some basics, and then I will go into the departments like head trauma, and then the thoracic trauma, and then the abdominal trauma, like that. Okay, fine. Padel, hello. Minakshi, very good evening, Minakshi. So let's start. So guys, first of all, a very basic first question is that if a trauma happened to any kind of patient, how to transport this patient to the hospital? Okay, so that is the question. How to transport, I think I need to, yeah, that would be better. How to transport the patient, right? Okay, so guys, first of all, the patient, you can transport the patient in the supine position. You can transport the patient in the supine position, and one should strap the head, thorax and pelvis of the patient. Head, thorax and pelvis of the patient. Why we are doing so? We are actually making sure that patient should be immobilized, right? Because we don't know, the patient might have, a very high grade of trauma. The patient might have polytrauma. The patient might have fractures at the different places. So we want to immobilize our patient, right? Okay. And before that, even we need to immobilize the spine also. We need to immobilize basically the cervical spine of the patient, right? And how we can do that? So I'm saying that, guys, protect the cervical spine, right? Protect the cervical spine of the patient as well. Now, how you can protect the cervical spine of the patient, guys? Well, you can do that by the help of Philadelphia collar or Philadelphia collar, or that is also called as the cervical collar, right? Cervical collar. So coming to the image section, as you can see over here, guys, what we can see is in this picture that, you know, these kind of volunteers, okay, what they did is on the hard board, right? They are actually taking the patient and they have strapped the thoracic region. They have protected the cervical spine of the patient, right, by using this weight, and they have strapped the patient well. Okay, so this is the proper way of, transporting the patient on the hardboard, and then they will take this patient to the hospital for further evaluation and management. What about a Philadelphia collar? As you can see right now in front of your picture, right? This is the Philadelphia collar, right? This is the Philadelphia collar. Okay, right. Now, so the take home point is you will strap the patient, okay, protect the cervical spine, take this patient to the hospital. Now, in some cases, a patient can be transported in the prone position as well. In what cases? Prone position, when there is, for example, uh, you know, severe facial injury. And in that case, what might happen, there could be a lot of secretions coming in the respiratory tract. So to prevent the aspiration, okay, so to prevent the aspiration, we might, to prevent the aspiration, we might actually transport the patient in the prone position as well. Okay, fine. Now there are two terms which are very commonly tested in the MCQs also. These are, what is the golden hour? So the question comes, what is the golden hour, right? And another question is, what are the platinum minutes? Very easy, guys. So actually, if you talk about the golden hour, this is the first hour following the trauma. Okay, so the first hour following trauma, after the trauma, the first hour is very, very crucial. If the patient has been transported successfully to the hospital, okay, and the patient gets the treatment within first hour of trauma, that will save a lot of time, and actually that will help in prognosis of the patient also. So first hour following trauma is very, very important, and that is called as the golden hour. What are the platinum minutes? So first 10 minutes following the trauma, first 10 minutes following trauma are the platinum minutes, right? Okay, now once we have talked about this, let me come to another important point, that is triage, right? So what is triage, guys? In the triage, we are actually grading the severity of the injury, right? What we are doing in the triage, we are grading the severity of injury, grading the severity of injury. Let's say you are outside, let's say you are in any kind of field setting, right? And let's say the bomb explosion happened over there, and during that time, okay, obviously a lot of injury will be happening. So you need to actually prioritize the patients, that what patient I can save, and what patient is actually very badly injured or severely injured, or so what patient needs emergency management, what patients are those kind of patients where we might delay the treatment also. So you need to prioritize your patients. So in those cases, the triage comes into role. Okay, it's a very important topic, right? Questions have been asked repeatedly from this topic as well. So here what we can see is we can prioritize our patient according to this. So first priority patient will be those where the immediate management is required, right? And that is the red color category patient. Actually, we are having the color coding, right? So in this color coding, we can see the red color, yellow color, green color, and the black color. Whenever you are visiting the hospital and you are visiting the trauma department of the hospital, right, emergency department, usually you will be seeing this kind of picture, right? First of all, you will be entering. Here is the here is one area, and that is usually red triage, okay, where the immediate management patients will be actually admitted, who needs the immediate management. And that's how, if they will be needing, if they will be getting the immediate management or immediate treatment, okay, they will be having very good prognosis, and they will be having very good chances of the survival, right? Then in this area, after that, in that area you might get the yellow category patient, okay. This is the red triage, this is the red triage, this is the yellow triage. And after that, in the hospital you might find the green triage patients, okay. Green triage patient, what do I mean by that? I'm talking about, let's say this is the hospital, okay. What do I mean by that? What do I mean by that? So I mean that, let's say, immediate management patient, okay, the patient who needs the priority. So first one, these are the red color. Now, what are the patients who are coming in this category, right? So the chest wound patient, okay, the open fractures patient, or the third degree burn patient, right? These kind of patients actually needs the emergency management, and if you will be able to do it successfully, then these patients will have very good prognosis for the survival, right? Then we are having the next category, that is the yellow color category, where the treatment might be delayed. For example, the limbs fracture, okay, the upper limb fracture, okay, or one lower limb fracture, okay. Here the treatment might be delayed. This is not very immediate management requiring condition, right? So this kind of condition like stable abdominal wound injury, right, or for example eye injury, or the CNS superficial CNS injury, that might be considered under this example. Then we are having a green category, okay, green category. In this case, what we can see is minor burns, lacerations, abrasions, okay, the minor cut injuries. So these kind of patient you can handle in the emergency at the same time, okay, providing the first aid, and you can send them home as well, right? So this is that category. This is the green color category. That's why the name tells you green category, okay. Then there is a black color triage. In the black color triage, already uh, high morbidity patients are there who are having very severe illness. Let's say head injury patient is there, severe head injury patient is there, whose GCS is 3. So these kind of patient are there who are having, who are very close to the mortality. So these are the black patients, and that's why they are coming in the last in this particular category, okay. So that's why in the hospital setting, first of all, we are having the red triage patient, then we are having the yellow triage patient, because the management can be delayed in this, and third one is the minor injuries patient, where you might see here or there lacerations, abrasions, or minor injuries, right? So I hope the triage thing is clear, okay. Then let's talk about the once the patient is coming to the hospital, when the patient came to the hospital, then you need to treat this patient also, right? And how will you manage this patient? Will manage the patient according to the ATLS guidelines, okay? According to the ATLS guidelines. So what are the ATLS guidelines, guys? So ATLS, first of all, ATLS means advanced trauma life support, okay. Advanced trauma life support, right? So according to the ATLS, okay, you need to you need to determine the severity of the injury. For example, you need to do the survey. You need to do the primary survey of the patient, where you need to look for the airway of the patient, breathing component of the patient. I'm coming to that. Then you are having the secondary survey of the patient. In the primary survey, what ATLS says is that we are having 4 category: A, B, C, and D. Now A for, yes, we are very well aware, airway. right? B for breathing, C for circulation, and D for disability. Okay, I will talk about them in detail. In the secondary survey, once you are done with the primary survey, first of all, you will be doing the primary survey. Once you are done with the primary survey, then you are coming to the secondary survey. In the secondary survey, we will be looking other kind of injuries. Okay, we'll examine the whole body of the patient. We'll look other kind of injuries. Sometimes the polytrauma patient are coming to the emergency, right? And there you might actually miss other kind of injuries. So if the patient is stable, okay, so what we are doing over here, looking for we are looking for other injuries in the patient. Okay, so first of all, we are doing the primary survey. We'll talk about airway, breathing, circulation, disability, and then we are coming to the secondary survey. If the patient is stable, if the patient is stable, then what we are doing, we can actually take the help of CT scan of the uh, CT scan of the body. We can do the CT scan of the body, and whole body CT scan can tell us very easily that if maybe the patient is having some kind of fracture or maybe some kind of any other problem. So CT scan of body might give you the better picture. Okay, if the patient is stable, because CT needs time. Fine. So primary survey and the secondary survey. Okay. In the primary survey, let's come. I'm coming to the main first part, that is the airway. Okay. So first part is airway. So first one, we'll do the airway management. Before doing the airway management, always remember, as I told you earlier as well, what you will be doing, you will be protecting the cervical spine, and that is very important. You will be protecting the cervical spine of the patient. How you will protect the cervical spine of the patient? Yes, we are very well aware. We may apply the Philadelphia collar or the cervical collar in the patients, right? Okay, then what kind of patients needs the airway management? Okay, if I'm talking about airway management, we are usually securing the airways by the help of intubation, right? So which kind of patient needs the airway management? So patients needs airway management. So what is this category? Okay, what patients uh, needs airway management? So the patients whose GCS is less than 8, or the patients who are unable to speak, right? Patients who are unable to speak, or the patients who are having the severe maxillofacial injuries, severe maxillofacial injuries, right? In those patients also, right, we are seeing that the patient is unable to speak. If very easy trick is, if the patient, you are actually trying to talk to the patient, you are trying to communicate to the patient can't speak anything. Okay, somewhere or other the patient's airways might not be secured. Okay, so your job is to do the airway management in that patient. Or in other case, you are evaluating the GCS of the patient and it came out to be less than 8. I will talk about the GCS in detail, don't worry about that, in the disability component. So if the GCS came out to be less than 8, guys, then also we'll be intubating our patient, right? Or I mean, we'll secure the airways of this patient. Okay, fine. So how we are actually securing the airway? Next question. So guys, we are having the facility of intubation, right? Intubation. And how, what are the types actually? First one is the endotracheal intubation, or some people call it as orotracheal intubation. Okay, you can call that as well, endotracheal intubation or orotracheal, or nasotracheal intubation, right? In case if the endotracheal intubation will fail, if it fails, then you can take the help of, okay, in case if it fails, then you're left with two options now. One is the emergency management and another one is the definitive management. In the emergency management, what you will do is, okay, you will do the needle cricothyroidotomy. Okay, I will show you. needle cricothyroidotomy, in the definitive management, you will insert the tracheostomy tube, right? We do the tracheostomy. Fine. Okay. Now, how to do the endotracheal intubation? As you can see over here, okay, with the help of laryngoscope over here, with the help of laryngoscope, right? We'll see the vocal cords. We'll try to look into the trachea of the patient, and we'll try to insert the endotracheal tube over there. Okay. The tube will be going inside, right? The tube will be going inside, and at the end of the tube, we know that we are having a inflating bulb, right? And once the tube is inside, right, we'll inflate this balloon. We'll inflate this balloon, and the tube will be fixed. Okay. Now, this is the endotracheal intubation. Okay. How we can do if it fails? Then I told you that needle cricothyroidotomy can be done. So in this case, what we can do is we can take the help of 14 gauge IV catheter, and we can insert it in the cricothyroid membrane, as you can see over here as well. Okay, the needle has been inserted into the cricothyroid membrane, and they got the access of the trachea, right? So this is the needle cricothyroidotomy which can be done in the patient, right? Okay. Always remember that nasotracheal intubation, okay, if somebody is doing the nasotracheal intubation, it is contraindicated in case of anterior skull base fracture. I will talk about the anterior skull base fracture too. Anterior skull base fracture. Okay, and there I will tell you that here the patient is having the cribriform plate fracture as well. So due to that, if one will try to insert the tube into the nose, okay, it might go through the cribriform plate fracture, right? And it will not go into the respiratory tract, obviously, right? So that's why nasotracheal intubation is contraindicated in the anterior skull base fracture. This has also been asked once. Okay, fine. Now we are done with the airway part. Now we need to evaluate the breathing part. Okay, in the ATLS guidelines, I told you in the primary survey, A, B, C, D, A for airway. Airway, we are done with that. I'm coming with the breathing part now. So in the breathing part, okay. So what about the breathing part? Okay, B for breathing. So in the breathing, look for these signs. Look at the chest. Okay, examine the chest of the patient. If the chest is moving or not. Okay, examine the chest of the patient. You can take the help of the imaging of the patient. You can take the help of chest X-ray, for example, right? If the patient is stable, let's say AP view, then uh, you can look for the pulse oximeter to evaluate the vitals. For example, what about the saturation of the patient, right? So these kind of parameters can be evaluated while evaluating the breathing part. Then you are having the circulation portion. Now in the circulation, mainly we are talking about the BP of the patient, blood pressure of the patient. Let's say the blood pressure of the patient is not stable, then we need to stabilize the BP of the patient, right? So in the circulation part, let's say if the BP is not stable, then what you will do? Okay, very commonly these kind of patients are coming, that blood pressure is actually lowering down, the patient is in shock. The patient might be in the hypovolemic shock, or the patient might be in the circulatory shock, the patient might be in any other kind of shock, right? Usually the patient is having following trauma, usually due to the blood loss, they are having the hypovolemic shock. So what you need to do is you need to insert two large bore cannula. In each hand you will insert the two large bore cannula. Okay, and minimum you need to insert 18 gauge cannula. Okay, whenever you are actually working in the surgery department or working in the trauma department, okay, very frequently they are actually putting the 18 gauge cannula, right? Can somebody name that cannula? What is the name? What is the color of the 18 gauge cannula? Can somebody name that in the chat box? Uh, what color I'm talking about if I'm talking about the 18 gauge cannula? Right? Okay, meanwhile you guys answer. Okay, I'm just moving forward. Okay, then okay, somebody answered. Aaron, Yeah, green color. Yeah, excellent. Actually, green color cannula is the 18 gauge cannula. Okay, minimum you need to put the 18 gauge cannula, that is the green color. You might put the 16 also, you might put the 14 also, right? But minimum 18 gauge cannula, so that we can actually give the fluid to the patient immediately, right? Okay, that is the motto of inserting this cannula. Now if the patient is actively bleeding, if the patient is actively bleeding, okay, active bleeding is there, right? In that case you need to give one drug, and the drug name is the tranexamic acid, guys. Usually it is very commonly coming with the name of Tranexa. So tranexamic acid in the case of active bleed. What are the indications usually for giving this tranexamic acid? If let's say the patient BP is systolic BP, I'm saying less than 90 millimeter of mercury, okay, or if the patient is profusely bleeding, I mean the active bleeding is there, or if the patient uh, heart rate is more than 110 per minute. In these kind of cases we are actually giving the tranexamic acid. And what is the dose of tranexamic acid? Okay, in case if somebody asks uh, what is the dose of the tranexamic acid, guys? So 1 gram, we are giving it 1 gram over 10 minutes, followed by 1 gram over 8 hours. Okay, so that is the dose of the tranexamic acid, right? It is very commonly coming with the brand name of Tranexa, right? Okay, in case if the patient is coming to you with the pelvic injuries, in case the patient is coming to you with the pelvic injuries, then okay, in the pelvic injury patient, pelvic injury patient, okay, yes, you will be using the pelvic binder. You will be use of pelvic binder. So you will be using the pelvic binder. How it helps, how the pelvic binder can might help this condition? Like look over here. Actually in this case you guys seeing this is the pelvic binder, guys, by the way. Okay, this is the pelvic binder. So what you can see over here is that it is having, you know, the straps, okay, and you can adjust accordingly. So if you are using this pelvic binder, what it is doing is it is pressing on to the pelvis. Usually the pelvic injuries are actually you know, bleeding profusely. So to stop the bleed, okay, to stop the bleed we are using the pelvic binder. If the pelvic binder is not available, let's say, then you might use any other means to, you know, just compress the blood vessels of the pelvis, right? That is the motto of it, right? So once we are done with the circulation part, so this was the circulation part. I hope you are clear till now. We have talked about the airway, then we have talked about the breathing part, then we are done with the circulation part, okay, where I told you about the role of the pelvic binder, the role of the tranexamic acid, right, and the role of giving the fluids to the patient, right? And minimum 18 gauge cannula, that is a green cannula. Okay, now coming to the disability portion, guys. In the disability part, in the disability part, so A, B, C is done. We are coming with the disability part. In the disability, we are talking about, in the disability, we are talking about GCS. Everybody knows that. Everybody knows that. What is the full form of the GCS, guys? What is the full form of the GCS? Anybody? While I'm writing the answer, okay, just I'm just leaving the space for you guys to answer GCS if somebody heard that right. Okay, GCS. So what is the full form of GCS? Okay. Uh, so here is the GCS, guys. Okay. Anyways, you might have seen it on the screen as well. That is the, yeah, very nice, very nice. I'm getting the answer. That's a Glasgow coma scale. Okay, wonderful. That's a Glasgow coma scale. So in this Glasgow coma scale GCS, we are actually checking the 3 parameters. Okay, what are these 3 parameters? The eye response of the patient, the best verbal response of the patient, and the best motor response of the patient, right? So in the trauma patients, okay, the very first thing, okay, obviously the primary survey will be done, A, B, C, and D. These are the must for the patient. If you're a doctor, if you're a health clinician, okay, our job is to evaluate this patient according to the ATLS guidelines, right? So A, B, C, D, disability. So guys, these 3 parameters are very, very important, and it indicates the status of the brain actually for these kind of patients, right? So first is the eye opening, okay, second is the best verbal response, and third is the best motor response. So EVM, the maximum score of GCS can be 15 and the minimum score of GCS can be 3, right? Okay. Next thing is, in the eye opening we are having maximum 4 score, right? So if you attended the patient and spontaneously the patient opened his or her eyes, then you will be giving the score of 4. If the patient is responding to your speech, responding to your voice, in that case the patient will be having the score of 3. If the patient okay, by giving the speech, okay, the patient is not responding, and then you give the stimulation of the patient by pinching to the patient, then patient opened the eye, then you'll be giving the score of 2 in that case. And if there is no response, obviously then minimum score is the 1. Coming to the verbal response, guys, if the person is oriented to time, place and person, you are trying to communicate to the patient, patient is responding very well, patient is answering to your questions very well, it is 5, right? Verbal response, it is 5. If the patient seems confused, okay, you are asking that where are you, and he just telling you that he's in some shopping mall or something like that, he's not in the hospital, let's say, he's not aware that where is he is confused actually. In those conditions you will be giving the score of 4. Let's say the patient is you are asking the patient, and patient is actually started abusing you, okay, or talking about something else, right? Inappropriate words they are talking about, then it is indicating the score of 3, okay, verbal response 3. If the patient is just mumbling, okay, just saying ma pa na, okay, these kind of words, then these are the incomprehensible sounds, and here the patient will be given score of 2, right? And in case if there is no response, obviously minimum score you will be giving, then that is the 1, right? Coming to the best motor response. Now, if the patient is obeying your command, you are saying, okay, show your tongue, patient is showing your tongue. Open your eyes, patient is showing you eyes, right? Okay, right? Show me your fingers, the patient is showing you fingers. These are obeying your commands, it means you're giving the score of 6. The patient is moving to the localized pain. What do I mean by that? You give the command, patient is not responding, and what you did is you pinched on the hand of the patient, let's say, and with the another hand patient is removing your hand. It means the patient is localizing the pain. In that case, you'll be giving the score of 5. Flexion withdrawal from the pain, that is the normal flexion, okay? You are pinching onto the hand of the patient and patient is doing like this is the normal flexion, right? Okay, flexion in response of pain, so that is, in that case you will be giving the score of 4. Let's say the patient is showing the abnormal flexion, the patient is showing the abnormal flexion or decorticate posture. In that case the patient will be given the score of 3, right? And if the abnormal extension, if the patient is showing this kind of posture, then in that case you will be giving the score of 2, and if there is no response you will be giving the score of 1, right? Best possible score, that is 15. Worst possible score, that is 3. And I told you GCS, if it is 3 of some patient, okay, very minimal chance of survival. Prognosis is very, very poor of those patients whose GCS is 3. Okay, fine. Probably the patient is in coma. Okay, now moving from here, the classification comes according to the GCS. I told you that the GCS is actually telling the status of the brain. So usually in the head injury patient, okay, GCS is very crucial. So if we're having, we can categorize the patient according to this classification, that mild head injury, moderate head injury, or the severe head injury. So accordingly we can categorize our patient. Okay, so what was GCS I asked you? So that is Glasgow Coma Scale. Glasgow Coma Scale. Okay, so now guys, if I will be saying that classification, then you can answer it very easily. So we are having, according to if I'll talk about the classification over here, then we are having mild head injury classification. We are having mild head injury. Okay, what is the GCS score over here? In the moderate head injury, what is the GCS score over here? And in the third one, severe head injury, what would be the GCS score over here? Okay, so in the mild head injury, usually, okay, GCS score is 14 to 15. Okay, in the moderate one, usually the GCS score is 9 to 13. Okay, or I would say 9 to 12. Okay, 9 to 13 or 9 to 12. Okay, 9 to 12. Okay, and mild head injury, you can say 13 to 15. Okay, 13 to 15. Fine. And severe head injury, it will be less than 8. Okay, and less than it, I told you, you need to secure the airways in the severe head injury patients. Fine. Now, sometimes I ask you, what is RTS? Okay, or RTS is the RTS is the revised trauma score. But once they asked actually, which of the following is not the parameter of RTS? So RTS, what is RTS? RTS is nothing but the revised trauma score. Revised trauma score. Like that, there are several scores as far as trauma is concerned, but this is a very important one, GCS, and then usually they ask about the revised trauma score. So RTS, in the RTS we are talking about three parameters. What are these three parameters? First one is the GCS, which we have talked about just now. Another one is the systolic blood pressure, and the other one is the respiratory rate of the patient. Fine. So this is about the overall idea of the trauma and the basics of the trauma, I would say. And now I'm going to jump into the the several departments, I would say. The head department, or you might say the organ also. So head, and then I will come to the chest part, thoracic part, and then I will come to the injuries regarding the abdomen, right? So I'm just going to start with the head trauma, guys. Okay. So in the head trauma patients, okay, started. Okay. So guys, let's start with the head trauma. Okay. So head trauma, if I talk about head trauma is the most common cause of mortality following the trauma, right? So it is very sensitive issue. If I are talking about the head, if you are talking about the brain, right? Uh, severe head injury patient, they go to the coma, right? And we are ventilating them, and the prognosis becomes very poor for them if severe head injury happens. So head trauma, it is the uh, I would say that most common cause of MCC, most common cause of mortality following trauma. Most common cause, okay, following mortality. Now, mortality following trauma, and usually we are actually seeing the skull fractures very commonly in the head trauma patients, right? So if you talk about the skull fractures, we are talking about the skull fractures very commonly in the patient, right? First one, okay, we might see the anterior skull fracture. Okay, we might see the anterior, anterior cranial fossa fracture. In the skull, we are having the fossas, anterior cranial fossa, middle cranial fossa, and the posterior cranial fossa. So let me just show you that as well. Okay. So here is the image, right? Okay. So if you will look this image, you can see that there is a anterior fossa, middle fossa, and the posterior fossa. And in the posterior fossa, we are seeing that there is a foramen magnum, right? Okay. So anterior fossa fracture might happen. You never know. Middle cranial fossa fracture might happen, or the posterior cranial fossa fracture might happen. So if the anterior cranial fossa fracture is happening, okay, very commonly what happens is, okay, very commonly the cribriform plate might get fracture as well. Cribriform plate fracture might happen. I told you that this is a contraindication for the nasotracheal intubation as well. Okay, I told you earlier in the basics of trauma. Okay, so that is the thing. Second thing is that the clinical feature, if you're talking about, okay, how will you identify? The patient came to the trauma unit, the patient came to your casualty, and you are a duty doctor over there, let's say. So in that case, how will you identify that this might be the anterior cranial fossa fracture? So if the patient is coming up with a very peculiar sign, I would say, that is raccoon eyes. Okay, raccoon eyes, also called as the black eyes. Okay, also called as the black eye. So this might be the indication that the patient might have the anterior cranial fossa fracture. Okay, along with that, what are other kind of things which you can see? Now, by the way, why raccoon eyes or black eye is seeing in the patient? Because the reason is due to subaponeurotic bleeding, right? Let me clear this picture. Look at this diagram first of all. Okay, so look at this diagram, guys. Here you can see what you can see, raccoon eyes. Okay, what you can see, raccoon eyes. So blackening of the eye, this is the raccoon eyes. Why it might have happened? Due to the anterior cranial fossa fracture. Okay, then look at this picture, the diagram of the scalp. Okay, the layers of the scalp. So in the scalp, this you can consider it as mnemonic also. So S for skin. Okay, I'm sorry. Yeah. So S for skin, then C for connective tissue, then A for aponeurosis, okay, L for loose areolar tissue, and the P for pericranium. Now, if the bleeding is happening just below the aponeurosis, if the bleeding is happening just below the aponeurosis, okay, then what might happen? Anterior cranial fossa fracture. In due to that, raccoon eye or black eye might be the presentation of these kind of patients, right? So that is the significance of knowing it. Okay, so I will just slide this diagram here. Okay, fine. So I hope you're clear with that. Then along with the black eyes, the patient might have the leaking of the CSF from the nose. Okay, and we are calling that as CSF rhinorrhea. We are calling that as CSF rhinorrhea. Or the patient might bleed from the nose. The medical term which we are using for that, that is the epistaxis, right? Epistaxis. Or along with that, the patient might have the anterior cranial fossa fracture, guys. So frontal lobe might have been injured. So frontal lobe contusions might be seen in this patient. So we might see the frontal lobe contusions. And usually it is not a very good fracture, to be very frank, because fracture of the frontal lobe, or I would say the frontal lobe contusions, okay, might have very bad impact on the brain, and due to that the patient might have the confusion. Okay, and the patient is not able to understand the things. Okay, the patient communication level is very poor. So this is the thing, frontal lobe contusions might have been seen. Some of the patient might lose the capacity to smell the things, and also anosmia might also be the feature. Now coming to the middle cranial fossa. Now if the middle cranial fossa fracture would be seen, middle cranial fossa fracture would be seen, middle cranial fossa fracture. Okay, by the way, this is very important question, guys. Black eye or the raccoon eyes, okay, this is tested very frequently. Anterior cranial fossa fracture, middle cranial fossa fracture, usually it happens because of the fracture the petrous part of the temporal bone. Okay, so usually it happens due to petrous part of the temporal lobe. Okay, fracture of petrous part of temporal bone. Okay, uh, how you can identify if the patient comes to your trauma unit? How will you identify that this might be the case of middle cranial fossa fracture? Okay, you will be looking over the mastoid process. This is the mastoid process, and you will be looking at this area. If you are looking the bruising over here in this particular area, okay, that is called as the battle sign. Okay, so the most important sign which we are seeing over here, that is the battle sign. And in the battle sign, what we are seeing, that this is the bruising or discoloration over the mastoid process. Okay, so discoloration or bruising over the mastoid process, bruising over mastoid process. Okay, okay, I think it is clear. Then the blood might come from the ears, so that is the hemotympanum, right? That is the hemotympanum. Okay, along with that, in some patients the CSF might come from the ear, that is the CSF otoria, CSF otoria, right? Then a very important phenomena, I would say, as far as exams are concerned, and a very interesting phenomena happens in these kind of cases, that is the uh, paradoxical rhinorrhea. Okay, paradoxical rhinorrhea. And what happens in this one, paradoxical rhinorrhea, is, okay, in this case what happens is that, yes, so guys, this was the battle sign, so I will just slide over here, slide below, so that you can see. Yeah, so this was the bluish discoloration over the mastoid process, uh, that is the battle sign. And here in this picture I will show you how the paradoxical rhinorrhea happens in the middle cranial fossa fractures, right? So here what you can see is that uh, you know this portion is the middle ear. Okay, this portion is the middle ear, and through the Strachan tube, the blood is actually filling up, in the middle ear. The blood is filling up in the middle ear. Through the Strachan tube, it will be actually coming over here. Okay, through the Strachan tube, it will be actually coming in the nasal cavity, and through the nose it will be coming outside. Okay, so that is called as the paradoxical rhinorrhea. Okay, now in some patients the facial injury might also be seen. Okay, facial nerve injury might be seen. Which cranial nerve is the facial nerve, guys? If can somebody answer, which cranial nerve is the facial nerve? Liberty Gaming, hello, hello, hello everyone. Dr. Siraj Khan, hello. Shashti Sharma, good evening. Uh, Anand replied 7. Okay, excellent, Anand. Okay, something interesting, very interesting answer. 7. Okay, so yeah, facial nerve is the seventh cranial nerve. Very well. So it is the seventh cranial nerve. Okay, so this injury might also be seen. Okay, guys. So I've told you about the paradoxical rhinorrhea also in this particular part, and about the battle sign. These are the highlight of the. Okay, so this is the highlight, battle sign, paradoxical rhinorrhea. Sometimes I ask you, but battle sign is very important. Okay, this is the middle cranial fossa fracture. Now, in some cases, you might see the posterior cranial fossa fracture as well. So let's talk about that also. Third one will be the posterior cranial fossa fracture. So posterior cranial fossa fracture, posterior cranial fossa fracture. So in these cases, occipital lobe is involved. Okay, I told you anterior cranial fossa fracture, frontal lobe contusions. Middle cranial fossa fracture, petrous part of temporal lobe is involved. Posterior cranial fossa fracture, I am saying occipital lobe is involved. Okay, if the occipital lobe of the brain is involved, okay, occipital lobe of the skull is involved, occipital part is involved, then which cranial nerve do you think, guys, can be injured in this case? Okay, very simple question. I told you that occipital part is involved in the posterior cranial fossa fracture. Which nerve might get injured due to this posterior cranial fossa fracture? How to diagnose paradoxical rhinorrhea? Anand is asking. So paradoxical rhinorrhea, you need to actually evaluate a lot of differential diagnosis. First of all, you might be thinking that the patient is leaking from the nose, so it might be the nasal cavity problem. Okay. So actually, first of all, you need to see whether it is blood only or the CSF. We have the test to actually do that. Just put that fluid, whatever it is coming from the nose, CSF or blood, whatever it is, we are actually putting on the uh, blotting paper, and then what we are doing is we are seeing it, and halo sign is coming. So outside ring will be seen as the CSF and inner ring will be seen as the blood. Okay, so if other signs of the middle cranial fossa are matching and you are seeing the CSF rhinorrhea, then you might think of paradoxical rhinorrhea, right? Otherwise you need to rule out by other means. Okay, now posterior cranial fossa fracture, I told you that uh, occipital lobe is involved, occipital bone fracture might be seen over there. Okay, something interesting answered to that question, sixth cranial nerve, Fidel to Anand 9 to 12. Okay, something interesting again gave very interesting answer. So that is the correct answer, sixth cranial nerve, because that is actually related with your vision actually. So sixth cranial nerve. Now again I'm asking one question, sixth cranial nerve is the name of which cranial nerve? So that is the question again. So if somebody can answer, meanwhile I'm writing that sixth cranial nerve is involved over here. Sixth cranial nerve is involved. So which cranial nerve I'm talking about? Uh, Question is again, sixth cranial nerve is also named as which cranial nerve? Okay, Anand answered is at very well. Abducent nerve. Yes, it is abducent nerve. Abducent nerve. Very well. Okay. Now coming to the management part, if you are trying to manage these patients, then how will you manage this patient? Okay. Uh, Anytime, every time there are chances of infection, so we'll be actually giving this patient or keeping this patient on the antibiotic. So prophylactically, we'll give the antibiotic to this patient. Usually, we are giving the uh, third generation cephalosporin. Okay, prophylactic antibiotics. Then, anytime, anywhere, if the head trauma is presenting to your trauma unit or your casualty, then the investigation of choice is always clear in our head, that is the NCCT, that is the non contrast CT scan of the head. NCCT head will be the investigation of choice in cases of head trauma, that is very clear. Okay, so here also we'll take the help of the NCCT head, right? Will not use the contrast over here, NCCT head. Then whenever if in any case the secretions are coming or CSF or blood is coming from either from the nose, either from the ear, as we talked about the anterior cranial fossa fracture and the middle cranial fossa fracture, we should not try to put some things into the nose or into the ear to in attempt to stop the bleeding from the nose or ear, because otherwise it will keep on accumulating inside the ear or inside the nose, and the bacteria, the opportunistic infections will be getting the chance to grow over there, and that will be problematic thing for the patient. So do not put anything into the nose, into the ear or into the nose to uh, uh, to protect that way. So it is not needed. Okay, then I'm coming with the main part now, that is the brain injury. So head trauma happened. I've talked about the skull fractures, anterior, middle, and the posterior cranial fossa fractures. Okay. Uh, yeah. So now let's talk about. Okay. Now let's talk about the brain injuries. Okay. brain injuries. Okay, brain injuries or brain injury. Fine. So in this case, what might be talked about? So I told you that what are the mild head injury, moderate head injury, and the severe head injury. Okay, you know that classification. You can add minor head injury also, where the GCS will be intact, 15 out of 15 maximum score. Okay, and without any loss of consciousness. Minor head injury, you had some laceration, you had some minor trauma, that can be considered as minor head injury. Okay, mild, moderate, and severe, we have talked about that. In case the patient came to your emergency or came to your trauma unit, the patient is having head trauma. Along with that, the patient is having non-recordable BP, or the patient is having very low BP, then in that case, think about the neurogenic shock also. In that case, you might think about the neurogenic cause also. By the way, the head injury patients are actually leading cause of mortality following the trauma. This is the leading cause of mortality following the trauma. Mortality after the trauma or following the trauma. Because GCS gets compromised very easily in these cases. And I told you that if the patient is coming to you, this is a scenario for you guys. If the patient is coming to you and the patient is coming up with a head injury, and the patient BP is very low over there. Okay. So in that case, you might think about the shock. Obviously, BP is decreasing, it might be the shock. Okay. So neurogenic shock should also be the differential diagnosis in your mind while you are evaluating this patient. So it might be the neurogenic shock as well in these kind of patient. It might be the neurogenic shock as well. Obviously, other kind of shocks might be there because due to the rapid blood loss, hypovolemic shock might be there, obviously, but neurogenic shock is also the differential diagnosis over there. Fine. Okay. Now, if the brain injury patient is coming to your unit, okay, brain injury patient is coming to your unit, brain injury patient is coming to your unit, okay, then what you will do actually? In that case, it can be the primary brain injury, either it can be the secondary brain injury, either it can be the primary brain injury, either it can be the secondary brain injury. Usually, primary brain injury happens whenever there is an impact. Okay, so high velocity impact or impact with any object or something like that. So the primary brain injury usually happens when there is impact. Okay, and the secondary brain injury usually happens whenever there is increase or elevation in the intracranial tension. So elevation in the intracranial tension, okay, or intracranial pressure, okay, whenever it is getting elevated, secondary brain injury might happen. Okay, that should be clear. Then I'm just gonna talk about over here primary brain injury, very commonly tested brain injuries. Okay, so in the primary brain injury, first of all, we are talking about the concussion. Okay, firstly, we are talking about the concussion. Now, concussion happens whenever during the contact sport. For example, rugby or kabaddi or football or something like that. Okay, so in these contact sport, the two players, the two players might get head injuries. So usually it is coming under the minor head injuries. Okay, for minute or two they might have confusion, and after that they might be coming back to their play. Okay, so you might have seen this during watching some kind of matches and all. So that can happen. So this is the example of concussion. Okay, where the two players during the contact sport, the head collision might happen, and followed by confusion, and then players are actually resuming their games. Okay, that is about the concussion. This is the mildest form seen in the head injury patient. One player, if it is getting he is getting the concussion, he is very lucky as far as head injuries are concerned, because this is the mildest form of head injury, guys. Okay, here also if somebody will ask you what is the investigation of choice, however it doesn't need the scan and all, but in case if the scan is happening, then NCCT scan is the investigation of choice, as I told you earlier as well, that in the head injury patient, obviously NCCT scan would be the NCCT head would be the investigation of choice, and usually it is coming normal. Okay, in these patient. So happening in what cases? It is the mildest form. Okay, seen in the contact sports. Okay, uh, here if you will do the NCCT of this kind of patient, it will be coming out as normal. Okay, third thing over here is that if you are uh, how to manage this patient, you don't need the intervention in this patient. Actually, the patient will be taking some break from their whatever game they are playing, and then coming back to the field and all. Okay, the the patient symptoms will be resolving automatically. Okay, fine. Now, next thing is the severest form of head injury, that is the diffuse axonal injury, and very commonly tested in the MCQs as well. So DAI, which is the diffuse axonal diffuse axonal injury. Okay, DAI is the diffuse axonal injury. In this case, what happens is it is the most severe form of injury. Okay, I told you earlier as well, it is the most severe form of head injury. Concussion was the mildest one, and this is the severest form of head injury. Over here, the prognosis, if I'm saying this, obviously the prognosis will be very bad. So worst prognosis, or I would say worst prognosis of such patients. Okay. In the diffuse axonal injury, if you are seeing the clinical features of the patients, okay, what will be the clinical features? The patient might be in the coma. The patient GCS will not be improving. So these are the clinical features, obviously. So clinical features would be the GCS. If you will be evaluating the GCS, serial monitoring of the GCS will not be helping in this case. GCS, let's say the GCS is 4 or 5, the GCS will not be improving from there commonly. So GCS is not improving. Again, GCS was Glasgow coma scale. So GCS is not improving. The patient might be in the coma state. Okay, so very bad injury. Now, if you will do the, I'm just repeating this line again and again. NCCT head is the investigation of choice in the head injuries patients, in the head trauma patient. But whenever you will be doing the NCCT of such patients, you are doing the NCCT of this patient, but NCCT will be coming out as normal, and that's how a lot of health clinicians might uh, might not have diagnosed this diffuse axonal injury, thinking that NCCT head is not showing anything. Okay, we need to actually move one step ahead in these cases, and we need to look for the MRI brain now. We need to look for the MRI brain, and in the MRI brain, it is showing you the finding. What kind of finding it can show you over there is that it might show you the punctate hemorrhages in the brain. Okay, so in the MRI, it can show you punctate hemorrhages. I will show you the image also. Punctate hemorrhages. Okay, punctate hemorrhages. So look over this image over here. Yeah, so this is the image of DAI MRI actually. Okay, MRI of DAI. So here you can see with the yellow arrow that this is the MRI of the brain, and you can see the punctate hemorrhage in this region. Okay, so this is the MRI of the DAI, diffuse axonal injury patients. Okay, then moving forward from here, so if they are asking you in the question, okay, very tricky question, head trauma patient investigation of choices, NCCT, non-contrast CT scan. In the diffuse axonal injury, the answer changes in this situation. In the diffuse axonal injury, if they are asking you the investigation of choice in the MCQ, then answer became the MRI brain, because in the NCCT you will not be finding anything. That will be coming as normal. So you will be going one step ahead in this case. You need to do the MRI brain, and there you will be finding the punctate hemorrhages in the MRI. So investigation of choice in DAI is the MRI brain. Okay, understood. Now, so investigation of choice, this became the question. Okay, MRI brain. Now, coming to the intracranial hemorrhages. Okay, inside the cranium, inside the brain. So intracranial hemorrhages, ICH, intracranial hemorrhages, intracranial hemorrhages. Okay, by the way, guys, are you guys enjoying? Please give me the thumbs up in case everything is fine and all, and you are understanding the stuff, what is going on. So we'll be talking about the ICH, intracranial hemorrhage, right? So four kind of things, four kind of things we are going to talk about in this intracranial hemorrhage. So one is the okay, Sanyasi Pandit. Okay, thank you, Anand. Thank you. Okay, okay, guys. What about others? Okay, meanwhile, I'm just moving on. Intracranial hemorrhage. So we might talk about the intraparenchymal hemorrhage, where the parenchyma might have been involved. Intraparenchymal hemorrhage. Right. Then we might talk about where the parenchyma will be involved. Then we might talk about the extradural hematoma or the extradural hemorrhage. Then the subdural hemorrhage, and then the subarachnoid hemorrhage, right? So starting with the very first one, that is the intraparenchymal hemorrhage or the IPH. Okay, intraparenchymal hemorrhage. So in the intraparenchymal hemorrhage, basically it happens due to the contusion. Okay, due to the head injury, obviously contusion happens and the parenchyma might bleed. And this is the most common type of traumatic head injury, right? So most common type of traumatic brain injury or brain bleed, most common traumatic, okay, brain injury. Something interesting says, sir, please cover GIT as well. I will try to do so. Thank you so much. So intraparenchymal hemorrhage, most common traumatic brain injury. So second one, okay, not the second one. First of all, let me just finish with this one. Yeah, IPH, intraparenchymal hemorrhage. So parenchyma of the brain will be involved over here. Most commonly, the temporal region is getting affected over here, followed by the frontal region. Okay, so most commonly, temporal lobe is affected. Temporal lobe is affected and followed by the frontal lobe. Right. Okay. And if you talk about the investigation of choice, if I will ask you, everybody will answer that as correct. I think that will be the NCCT head, right? So investigation of choice, no need to repeat, guys. Investigation of choice will be the NCCT head in this region. NCCT head. Okay, intraparenchymal hemorrhage. Okay, management is usually conservative. No need to intervene in this patient. No further intervention is needed. Just we need to manage it conservatively. So we are doing the conservative management only in this patient. Okay, conservative management we are doing for these patients. Now, second point is the second one is the extradural hematoma. Just writing the full form as well. However, everybody knows this extradural hematoma or extradural hemorrhage. Okay. Okay, whatever your heart says. Okay, just say that extradural hematoma or hemorrhage. Now, EDH, usually it happens in the young patients. Okay, or I would say the young generation. Uh, Usually it happens in the young generation, young patients, which are coming to your trauma unit. Very commonly, these are the young patients, the bikers. Okay, the accident, the head trauma, or I would say the road traffic accidents. Okay, RTA with head injury. These kind of cases are coming very commonly. Okay, extradural hematoma or hemorrhage, right? Uh, it usually happens due to high velocity impact. Obviously, the biker came to you, or there was car accident or something like that. High velocity impact will be causing this extradural hemorrhage, right? So the bleeding will be happening basically outside the dura, outside dura. Okay, outside the dura, so between the skull and the dura, the bleed will be happening, and usually over here, middle meningeal artery gets injured. Okay, middle meningeal artery get injured at the pterion region, and that's how it will be leading to the extradural hematoma. So which artery is involved? That is the MMA, middle meningeal artery. Okay, that is the middle meningeal artery injury happens over here. So middle meningeal artery gets injured over here. Okay, now if you are talking about the clinical feature, a very important clinical feature, very interesting clinical feature happens in this case or seen in this case, that is a lucid interval, and that has been tested a number of times in the MCQs. So if I talk about the lucid interval, okay, just highlighting as well. So lucid interval, that has been tested a number of times over here. So what is lucid interval? What does it says? So lucid interval, guys, nothing but actually it is the period of normal consciousness between two episodes of unconsciousness. Okay, so it is the period of, it is a period of you know it is the period of normal consciousness, normal consciousness, normal consciousness, okay, between two episodes of impaired consciousness, impaired consciousness. Okay, fine. Okay. Ray the old gamer, okay, of the dura. Okay, I'm talking about in the extradural hematoma. I was saying that between the skull and the dura mater, in the meninges, if we are talking about, then we are having the three layers, right? So the dura mater, okay, pia mater, arachnoid mater, right? So I'm saying that the outermost layer of the meninges is the dura mater. Outside the dura mater is the skull. So between the skull and the dura mater, if the bleed is happening, then that will be considered as the EDH or the extradural hematoma, right? Okay, now let me just describe the example of lucid interval also, because it is tested very commonly. Once this kind of question came as well, that a player is actually playing, and he's actually doing the batting against a fast bowler, and the bouncer came and it hits onto the head of the the batter. So obviously the player got injured, okay, and he was having the impaired consciousness, okay, and and he got back to the dressing room with the help of the health clinician and healthcare staff, and then after some time he got the consciousness back, okay, he got the consciousness back, okay, and he came to the ground again, okay, and then what happened is that again he got impaired consciousness, okay. So in this scenario what has been happened is that this is the FMG question, by the way, I think came in 2020. So this, why this happened, so this is the case of lucid interval, okay. They will not ask you this is the lucid interval, they will ask you what is the diagnosis, what is the differential diagnosis, or what is the diagnosis. So obviously option will be like intraparenchymal hemorrhage, or the extradural hemorrhage, subdural hemorrhage, or the subarachnoid hemorrhage. So obviously in that case your answer will be the EDH, or the extradural hemorrhage or hematoma, right? Because they are describing you the lucid interval. So period of consciousness between two episodes of impaired consciousness or the loss of consciousness, that is the lucid interval. Okay, now uh, in the NCCT, obviously investigation of choice is the NCCT head. Investigation of choice is the NCCT head. NCCT head. Okay. So yeah, Anand, yeah, it is close to pterion. Middle meningeal artery is going close to the pterion, so that's why it is the most common area. So NCCT head, and in the NCCT head, what is the presentation? In the NCCT head, what is the presentation? That is actually uh, the biconvex lens appearance. Okay, that is actually the biconvex lens appearance. Okay, the biconvex lens appearance. Okay, how it is looking in the CT scan also. Let me just show you. This is the NCCT scan of the extradural hematoma, and here you can see the biconvex shape. Okay, over here that is seen. Okay, or you might see, you can say the lens shape, biconvex lens shape appearance is seen over here. This is the pterion region where the middle meningeal artery is going, and that gets injured. Due to that, this kind of appearance can be seen. I hope I am clear, guys. So this is the extradural hemorrhage. Okay, and pterion here, the which artery? Middle meningeal artery will be gets injured. Okay, be getting injury. Okay, guys. I hope I'm clear with that. Okay, middle meningeal artery gets injured. Okay, fine. Now coming to the next part. Okay, before that, how to manage this patient? Manage will be, we need to do the craniotomy or the burr hole. So craniotomy, or will make the hole into the skull. Neurosurgeon will do that. So we'll make the hole into the skull. That is a burr hole. So make the burr hole over there. So craniotomy or burr hole would be the surgery. Okay, fine. Wherever the EDH is present, usually near the pterion, they will be making the hole over there. Okay. Next one is the EDH. We are done with that. Next one is the subdural hemorrhage. SDH is the subdural hemorrhage or subdural hematoma. Subdural hematoma, right? Subdural hemorrhage or subdural hematoma. So in the SDH, we are talking about usually three periods, okay, or three category, I would say. One is the acute. Okay, so we are having the acute SDH, we are having the subacute SDH, and we are having the chronic SDH. Okay, in the acute SDH, we are saying less than 3 days. Okay, the presentation, the patient will be presenting in less than 3 days. If the patient is presenting between 3 to 21 days, then it is subacute presentation. And if the presentation is more than 21 days, then it is the chronic subdural hemorrhage. Most usually it is seen in the elderly patient. I told you extradural hematoma is seen in the younger generation patient, but I'm saying SDH now, subdural hematoma or hemorrhage, is seen in the older age people. Okay, and usually the presentation is chronic over there. Okay, so following trauma, the elderly patient following trauma is usually presenting with the chronic SDH presentation, right? Okay, what blood vessel will be injured over here. So I told you in the extradural hemorrhage or hematoma, middle meningeal artery was involved. Okay, and over here in the subdural hemorrhage or hematoma, the cortical bridging veins will be involved. So cortical bridging veins will be involved. Cortical bridging veins gets injured. Gets injured. Yeah. So cortical bridging veins will be getting injured. Yeah, Ray the Gold Gamer, bridging veins. He answered, yeah, very well. Anand, biconvexity, yeah, I think you answered that for EDH earlier. Okay, nice. So, okay, once we are done with the SDH, this was about the SDH. Investigation of choice, no need to ask you guys, that is the non-contrast CT scan of the head, NCCT head. What will be the finding? NCCT head will be done in this patient. And what will be the finding, guys? NCCT head, you'll be seeing the concavo convex, right? So crescentric, it is also called as the crescentric hemorrhage. Okay, crescentric hemorrhage, or as I said, concavo convex. Okay, concavo convex hemorrhage. Okay, let me show you as well. So this is the NCCT scan of the subdural hemorrhage patient, subdural hematoma patient, and here what you are seeing is crescentric hemorrhage, right, or concavo convex appearance, right? So this appearance you are seeing over here, crescentric or uh, concavo convex appearance, right? Okay, fine. Now coming to the next one, guys, the fourth one is the SAH, that is the subarachnoid hemorrhage. That is the subarachnoid hemorrhage. Subarachnoid hemorrhage or hematoma. Okay. Yeah. Okay. Anand Ray or the old gamer, very well. Okay, subarachnoid hemorrhage. Okay, so usually in the subarachnoid hemorrhage, what we are seeing is most common cause is the trauma, and uh, you know uh, what happens is that minor fissures might be getting injured over there. So for example, sylvian fissures might be getting injured. So I will show you the diagram as well. So most common cause is the trauma. Most common cause is the trauma. Investigation of choice will be the NCCT. Investigation of choice will be the NCCT head. Okay, managing, how they will be managed? They will be managed conservatively. Look at this NCCT. Sometimes they might ask you the NCCT of the subarachnoid hemorrhage. That's why I'm showing you this. So SAH. So this is the image of the subarachnoid hemorrhage. You can see some of the sylvian fissures might be getting the fillings. Okay, so the blood might go into there. Okay, so this is the subarachnoid hemorrhage picture. Okay, fine. Now this was about the trauma. This was about the hemorrhage actually, in the head trauma, that we have talked about the extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, and before that we had to talk about the intraparenchymal hemorrhage. Okay, now here the fact point, I'm just adding that what is the brain death. So when we are saying that there is a brain death in the patient, so we are usually saying that whenever there is no possibility for the recovery of the patient. So there is no possibility of the recovery of the patient. In that case, we are saying that there is a possibility is not there, no possibility of brain recovery, of brain function recovery. Okay. Secondly, two clinicians. Okay, two clinicians are needed to declare the brain dead. Two clinicians are required to declare the brain death. Okay, sometimes to declare the brain death. Okay, sometimes they ask you. Fine. Okay, and criteria GCS will be less than 3. Okay, the pupils will be non-reacting to light. Okay, and there will be no brainstem reflex, there will be no reflex. GCS will be 3. In this kind of patient, we say that brain is not responding at all, and we declare them as brain dead. Okay, so this was about the head trauma, head trauma class, and we are just coming back with the 5 minutes break. Okay, meanwhile you have your snacks and all, and we are just coming shortly back. Okay, thank you. Hey guys, welcome back. So let's resume our discussion. So we have talked about the basics of the trauma, and we have talked about the head trauma aspects. We have talked about the EDH, SDH, SAH, IPH, interparenchymal hemorrhage. We have talked about the anterior cranial fossa fracture, middle and the posterior cranial fossa fractures. And now we are moving to the next department. From the head department, now we are moving to the next department, or you would say the next region, that is the chest region. Okay, so coming below now, chest region, or the I would say thoracic region. So let's talk about the thoracic injuries or the thoracic trauma, right? Meanwhile, just give me the thumbs up that everything is fine. You are good with audio and the video. Okay, okay, thank you, thank you. Okay, thank you. Mithilesh Patel, hiatus hernia. Hiatus hernia is not related to this one. Hiatus hernia it happens in the lower esophageal region. Okay, I will be talking about that when I will be talking about the GI surgery. Okay, I will talk about that in the detail. Okay. Yeah, Mithilesh, I will talk about that hiatus hernia when I will be talking about the GI surgery. Okay, fine. So I think everything is fine. Okay, fine. So guys, just resuming with the thoracic trauma. Okay, or whatever patients are coming with chest injuries and all, we are dealing with the thoracic trauma. Okay, it is very commonly seen in the polytrauma patients usually. Okay, so how it is happening? You know, we are having two scenarios. One is the blunt trauma injury patients, and another one is the penetrating chest trauma patient. For example, blunt trauma injury patients might be those who met up with the road traffic accidents, the car accidents. Okay, where the thoracic cavity just hit with the had an impact with the steering wheel, and ribs got broken, or the chest injury might have been happened. That is a blunt chest injury. And on other case, penetrating chest injury might also be seen where somebody just stabbed the patient into the thoracic cavity with the knife, or with some gunshot or all, right? So that will be the case of penetrating chest injury case. So one could be the blunt trauma, or I would say the blunt thoracic injury or blunt chest injury, right? And another one would be the penetrating one, right? Penetrating chest injury. Okay, fine. Penetrating chest injury. So in the blunt in the blunt chest injury, what is happening? Usually the upper respiratory region is getting involved. Usually the trachea region or the bronchi region or the bronchial region. Okay, these kind of structures might be injured in the blunted chest injury or the blunt thoracic injuries. While in the penetrating injuries, usually the most common cause of death is the hemothorax. And why the hemothorax is happening in those cases? Due to the pulmonary lacerations. Because whenever the patient is getting stabbed by someone with the knife, let's say, and the knife is getting entering into the thoracic cavity, obviously it will be hitting the lungs, right? And whenever it will be causing the injury to the lungs, obviously the lungs will bleed, and that blood will be coming into the pleural cavity. Okay, and due to that, hemothorax will be seen in these patients. So I will talk about the hemothorax shortly in this particular thoracic injury class only. Okay, so in the blunt chest injury patients, the trachea injury or the bronchial injury. So tracheobronchial injuries are the main culprit, right? They are causing the mortality in the patient, right? Usually, and in these cases, penetrating chest injuries patient, usually the hemothorax, due to the pulmonary laceration. Okay, due to the pulmonary laceration is causing the mortality in the patient, right? It's causing the mortality in the patient. Okay, so chest injuries. thoracic injuries, blunt trauma injuries, penetrating trauma injuries, right? Usually whenever these kind of patient comes in the thoracic trauma, in the head trauma, I told you investigation of choice was the NCCT head. In the head trauma patients, I told you investigation of choice was the NCCT head. And in the thoracic trauma, I am saying that investigation of choice would be taking the chest x-ray, but not in the PA view. Obviously, the patient would be bedridden in your trauma unit. So you have to take the x-rays in the AP view only. That is the anterior posterior view. The C-arm x-ray machine will take the x-ray of the bedridden patient. Okay, so investigation of choice, guys. Okay, so investigation of choice would be the chest x-ray, not the AP view but the PA view, as the patient can't stand and all of those things. Okay, fine. And we might take the help of E-fast. What is E-fast? E-fast is E for extended focused assessment of sonography in trauma. Okay, so obviously in your trauma unit only you will be having this facility. Okay, so in the trauma unit only you will be having this facility that there might be one radiologist, or there might be a well-trained clinician who will be actually examining the the abdominal region, upper abdominal region, and mainly the thoracic region to evaluate any kind of visceral injury. Now let me just talk about the EFAST over here. This is the diagram of the EFAST. Let me just give you the broad idea, right? Okay, so here what you can see is that first of all you will be putting your probe in this area, that is the right upper quadrant area. Then you might put your probe in the left upper quadrant area, right? Then in the subxiphoid area and the suprapubic area, then in the right anterior chest area, and then in the left anterior chest area. So the motto is that actually you will be looking through the body. Okay, if I'm removing the fifth and sixth one, then I will be saying it as fast focused assessment sonography in trauma. And if I'm including the 5 and 6, it becomes the extended fast. It means I am looking into the right anterior and the left anterior chest also. What is the purpose? I can look for the peritonitis, I can look for the pericardial effusion, I can look for the pneumothorax. Okay, so this is the motto for doing the E-fast. Okay, and it doesn't take much time. Okay, fine. Okay, so once we have understood about the fast technique, then I'm just moving on to the main thing over here, that is the ribs fracture. Because whenever you will be thinking about the blunt trauma injury patient, the car is actually got hit by someone, and there was a road traffic accident, car accident, and the ribs might have been injured. So in this case we are talking about the ribs gets fractured. Okay, so ribs fracture will be seen over here. So in the ribs fracture, what we are seeing is most common type of thoracic injury. Most common type of thoracic injury is the ribs fracture. Thoracic injury. Okay. Secondly, most common type of thoracic injury, right? Secondly is it is usually very commonly seen in adults, because obviously the car accidents and all, usually it comes the adults age group are coming into this range. Third thing is, if you talk about the clinical features, the pain in this particular area wherever the ribs are present, and usually in the ribs injury patient, ribs fracture patient, you will be seeing the bruising in this particular area. Why you are seeing the bruising in this particular area? Because the blood might have been leaking out from that space, and it is causing that bluish discoloration in this particular area. So bruising can be seen and the pain can be seen. These are the two important clinical features in these patients. So bruising and the pain in that area. Okay, these are two important features. How will you treat? Actually, adequate analgesics you will be seeing basically, and you will be giving the analgesics, and then after that you will be actually analyzing other kind of ribs injuries. So you can take the help of the chest x-ray AP view, that is the investigation of choice in these kind of cases. And usually sometimes I ask you a question that during the CPR, what ribs are getting injured very commonly. So during that time, third to fifth ribs are usually involved. So during CPR or while giving the cardiopulmonary resuscitation during CPR, okay, while doing the CPR, third to fifth ribs are commonly got fractured. Okay, got fractured. This is a sign of fracture. Okay, I'm just drawing the sign of fracture like this. Dash. Okay, fine. Second thing, after the ribs fracture, okay, in this area only, we are coming up with a very important topic, that is a flail chest. Okay, what is the flail chest concept? So let's talk about that as well. So in the flail chest, we are talking about flail. Okay, flail chest. So flail chest means, these are the ribs like that. Okay, so two consecutive ribs fracture. Okay, so two consecutive ribs fracture at two or more places will be termed as or will be considered as the flail chest. Okay, so I'm just writing the definition. So two or more ribs fracture. Okay, two or more ribs fracture at consecutive places. I mean two or more places, right? At two or more places, that will be considered as flail chest. I will show you the diagram also. Okay, of the flail chest. Yeah, so here you can see the rib fracture injury. So ribs have been fractured over here. Okay, and you can see the bluish discoloration, bruises over here. Here you can see the ribs injury. Okay, the ribs might have been fractured, and you can see the callus formation around that. And okay, yeah, here is the flail chest. So you can see that this is the flail segment, and you can see the fracture has been there, two or more consecutive ribs at two or more places. Okay, that is the definition. So two or more ribs have been fractured over here. This is the flail segment, and what a very interesting phenomenon is seen over here. I told you that in the middle cranial fossa fracture, paradoxical rhinorrhea, I told you one interesting term. Here the interesting term which I'm adding over here is, that is the paradoxical chest movement. Okay, that is a paradoxical chest movement. And what do I mean by that? So paradoxical chest wall movement, usually what happens is whenever we are actually inhaling the air. Okay, whenever we are actually inhaling the air, okay, our what happens is that our chest cavity, okay, is moving outside. But in this case, and vice versa. But in this case, what will happen whenever we are inhaling the air, whenever we are doing the inspiration, the pleural segment area will go inside, and during the expiration, it will go outside, right? So that kind of paradoxical chest wall movement will be seen in these cases. So that's why in the inspiration, they are saying that during the inspiration, okay, what is happening? It is going inside, and during the expiration, the flail chest segment is coming outside. That is a paradoxical chest wall movement. Interesting phenomena seen in the flail chest. So just remember paradoxical chest wall movement. Okay, they test this thing very commonly in the MCQ. So this is very important. Okay, then usually we are giving the oxygen to these kind of patient. Adequate analgesics you need to give to this patient, right? For example, NSAIDs and all, you need to manage the pain in these kind of cases, because obviously severe pain will be there. Now next thing, after the flail chest, we are coming with a very important term in the thoracic injuries, and very frequently tested, that is the pneumothorax. So let's just talk about the pneumothorax as well. So pneumothorax, right? Okay, pneumothorax. So guys, if you talk about the pneumothorax, then it is the accumulation of air in the pleural cavity or in the pleural space, right? Air in the pleural cavity or in the pleural space. Now, if you're talking about this air in the pleural cavity, then it is having types: pneumothorax, open pneumothorax, closed pneumothorax, tension pneumothorax. So what are these types? Let me just tell you with the help of this particular diagram only. Here what you can see is that this is the pleural cavity. First of all, let me just tell you the normal thing. This is the lung, L for lung, and this is the pleural cavity. Obviously, this is the pleural cavity. This is the normal side. I'm just talking like this. Okay, and here you can see lot of air is actually filling in this side of pleural cavity, and the lung is getting compressed, right? Here they are naming it as closed pneumothorax, and here they are naming it as open pneumothorax, having similar pictures. How can you differentiate? So thing over here is, guys, in the closed pneumothorax, okay, in the closed pneumothorax, okay, there is pulmonary laceration. Okay, in the closed pneumothorax there is pulmonary laceration. Let's say there was pulmonary laceration, the air was coming outside and the air is coming inside the lung, again and again, again and again. So air is coming outside, air is coming inside. Okay, so from the outside air is not coming, but from the lung air is going into the pleural cavity, from the pleural cavity air is going into the lung. So that kind of scenario is seen in the closed pneumothorax. Okay, that's why they are showing you the both arrows. In the open pneumothorax, air will be coming inside. Okay, air will be coming inside, okay, into the pleural cavity. Okay, sometimes it is not coming outside. Okay, so sometimes it can cause the tension pneumothorax also. In the tension pneumothorax, what it is doing is that it is compressing the mediastinum, and it is compressing the trachea, bronchi, and the chest into the opposite direction. So it is compressing into the opposite direction, and that will convert it into the tension pneumothorax. So here you can see the X-ray of the tension pneumothorax patient, right? Tension pneumothorax patient. Okay, tension pneumothorax patient, and what you can see over here is that on the X-ray the air is looking black in color. So you can see the air is actually filling up in this area. Okay, and the lung is getting compressed. Okay, and it is trying to push the mediastinum onto the opposite side. So this is the example of tension pneumothorax, X-ray of the tension pneumothorax. Okay, I hope you are clear with that. Fine. Now, so pneumothorax, basically it is having the category simple pneumothorax or the tension pneumothorax. Okay, in the simple one where we might talk about the closed pneumothorax or the open pneumothorax. I have explained you what is the closed pneumothorax or the open pneumothorax according to the diagram, right? And then it can actually convert it into the tension pneumothorax, right? Okay, now if you talk about the tension pneumothorax, usually they are very commonly testing the tension pneumothorax in the exams. Okay, so let me just talk about that as well. So if you talk about the tension pneumothorax, right? Tension pneumothorax. So what will it be? So I told you, I gave you the basic idea that mediastinum is getting pushed onto the opposite side, and the trachea, bronchi, all of these things are getting pushed to the opposite side. And on one side, air is getting accumulating in the pleural cavity. On the other side, other lung is getting compressed against the chest wall. Okay, and the same side lung will be getting so much of compression. Okay, so all of these things you might write also that shifting will be seeing the trachea and the mediastinum shifting will be seeing to the opposite direction. Mediastinum shifting will be seen to the opposite direction. To the opposite direction. Okay. Next point is that while talking about the same side of the lung, same side of the lung will be getting compressed. Same side of lung will be getting compressed. Same side of lung will be getting compressed, and on the opposite side, whatever lung is present over there, it will be getting compressed against the chest wall. Okay, so other side lung will be getting compressed. Other side lung will be getting compressed. Will be compressed. Okay, and it will be compressed very severely. Same side of the lung will be getting compressed very severely, as we saw in the chest X-ray as well. Okay, now moving on from here, let's talk about the clinical features also. If you talk about the clinical features, guys, then usually what happens is you can see the tachypnea, it means the respiratory rate is increasing. You can see the tachycardia, that means increase heart rate. Okay, you can see the decrease in the cardiac output. Due to that, you will be seeing that there is a decrease in the systolic BP. Okay, due to that, you will be seeing that there is a decrease in the systolic BP. So decrease cardiac output, decrease systolic BP. Okay, and one very important feature we are seeing that the distension of the neck veins. Distension of the neck veins will be seen because of increased in JVP. So jugular venous pressure will be increased, and due to that distension of the neck veins will be seen, right? Due to that distension of the neck veins will be seen. Distension of the neck veins will be seen, right? Okay. Now, usually cardiac, we'll be talking about the cardiac tamponade also. Cardiac tamponade features and the tension pneumothorax features are almost similar to each other. I will talk about the clinical feature of the tension pneumothorax. I have talked about that. And the cardiac tamponade clinical features also are same, right? So how will you differentiate the cardiac tamponade with the tension pneumothorax? So tension pneumothorax, one very important feature is that there is a absent breath sounds, while in the cardiac tamponade, we'll be talking about the back striate, and there I will tell you that it will be having the muffled heart sounds. So please keep in mind that differentiating point, and as they are very similar to each other, it is very commonly tested in the MCQs as well. Okay, fine guys. Then if you talk about the tension pneumothorax diagnosis, how will you make the diagnosis? Would you take the help of some kind of investigations in making the diagnosis of tension pneumothorax? The answer is absolutely no. We can't wait for the investigations to come over here. We don't have even time for doing the chest X-ray of the patient, because we need to actually evaluate this patient purely clinically. Okay, so clinical diagnosis is very important in these tension pneumothorax patient. Okay, and the time is very crucial in these patients, right? So in these patients, usually we need to buy the time. Okay, so how I'm saying we need to buy the time actually. So talking about the management guys over here, we have two options. Okay, so just saying that if you talk about the diagnosis purely clinically, you can support your diagnosis by the help of investigations, but clinical diagnosis you have to meet. Now, as far as treatment is concerned, okay, you have two options. One is the emergency management and another one is the definitive management. So one is the emergency management and another one is the definitive management. Okay, in the emergency management, we are talking about the needle thoracocentesis. Okay, we are talking about the needle thoracocentesis, right? Now, in the needle thoracocentesis, what we are doing is we are actually inserting the wide bore needle. Okay, we are inserting the wide bore needle. Insertion will be done. Okay, now if you are doing that in adults, you might do that in children also. In the adults, if you are doing, do that in the fifth intercostal space, in the fifth intercostal space anterior to the mid-axillary line. Do that in the fifth intercostal space, okay, anterior to the mid-axillary line. Anterior to the mid-axillary line. Okay, fine. So Anand told, yeah, tracheal and mid-external shift to the opposite side. Yeah, very well answered. And hyperresonance in the affected area. Yes, very well. But over here, please remember the point, breathing sounds will be absent. That is very important point over here. Okay. Yeah, I am coming to that. So in the children, you will be doing that in the second intercostal space. In the children, you will be doing that in the second intercostal space in mid-clavicular line. Mid-clavicular line. Okay, fine. Now, if you talk about the definitive management here, if you talk about the definitive management, what we can do is we can put the intercostal tube in the triangle of safety. Okay, so we need to do the tube thoracocentesis. So now we are putting the tube thoracocentesis, and in the tube thoracocentesis, what we are doing is we are actually inserting the intercostal tube, right? So ICT insertion, intercostal tube insertion in triangle of safety. I will talk about that. What are the triangle of safety? What are the borders of the triangle of safety? Sometimes they ask you. So that will be done. Okay, fine. So let me just show you how the intercostal tube drainage looks like. So over here you can see this is the triangle of safety I'm talking about. The borders are the base of the axilla, the lateral edge of the pectoralis major, and the lateral edge of the latissimus dorsi, and the fifth intercostal space, right? These are the borders, and in this area we'll be putting the intercostal tube. Okay, while we are inserting the intercostal tube, we are inserting through the upper border, not in the lower border, as the neurovascular bundle might get injured, right? If you are inserting in through the lower border. Okay, so you should know this. So guys, very simple. Pneumothorax, air in the pleural cavity. It can be simple pneumothorax, tension pneumothorax. Simple pneumothorax might get converted into the tension pneumothorax. We have talked about the open pneumothorax, closed pneumothorax, and the tension pneumothorax. Open pneumothorax, due to the pulmonary lacerations. Okay, in the closed pneumothorax, due to the pulmonary laceration, the air might come from the lung into the pleural cavity, from the pleural cavity back into the lung. Then in the open pneumothorax, pulmonary laceration will happen. Okay, sorry, the laceration will be there in the pleural cavity, and from there air might go inside the pleural cavity, but from there it might not get the way outside, so that's why it can cause the tension pneumothorax. Okay, however, close or open, okay, both can sometimes cause the tension pneumothorax. Now, tension pneumothorax, I told you, the mediastinum, the trachea, all of these things will be shifting to the opposite side, right? So the same side lung will be getting so much of compression, right? So that was the absent breath sound is the main important point. I've highlighted the clinical features of the tension pneumothorax as well. So now I'm moving on to the hemothorax now. Okay, so now I'm moving on to the hemothorax of the. Okay, so yeah, so moving on to the hemothorax. So what is hemothorax? Hemothorax is simple. Hemo means blood. So blood accumulation in the pleural cavity, right? So blood in the pleural space or pleural cavity. Okay, that will be called as the hemothorax. Okay, usually I told you what is the investigation of choice in the thoracic injuries. That was chest X-ray. That was chest X-ray. Chest X-ray was investigation of choice. So usually what we are doing in the hemothorax. If we are doing the chest X-ray, okay, then what is happening? What you can see that air fluid level. I will show you how the air fluid level looks. Okay, so air fluid level can be seen over there. Now, usually what happens is how the intercostal vessels are getting, how the hemothorax is getting involved over here, how the hemothorax is happening in the patients actually. In these cases, either the pulmonary laceration might happen due to the penetrating injuries and all, okay, or the intercostal vessels might get injured in the blunt trauma injuries. So blunt chest trauma injuries. So what might have been happened over here is that, okay, the damage of intercostal vessels might cause this particular injury. Okay, fine. Now, what you will do, management will be the same. We need to insert the ICT. Okay, so ICT insertion will be done in these cases. Okay, intercostal tube insertion will be done in these cases as well, where you will insert it in the triangle of safety. In the triangle of safety, right? Done. Okay, guys. Now, as far as chest tubes are concerned, I told you that what are the borders of the triangle of safety and where we will be putting it inside the thoracic cavity. Now, how will you check the functioning, that whether the functioning of the chest tube is working or not, whether the chest tube is working or not, and whether it is placed in a right manner or not. So when you will be looking at the X-ray, okay, and you will looking at the X-ray, actually ICT, intercostal tube, is having the radio opaque line, so it can be easily look into the chest X-ray. So whenever we are putting the ICT, okay, always we are asking for the chest X-ray, right, following the ICT insertion. So you can easily follow the ICT pathway in the chest X-ray. Now, I'm just moving on to the one more very important aspect, that is the cardiac tamponade. Okay, however, I gave you the hint of cardiac tamponade. At least you can tell me the clinical features of the cardiac tamponade. That was decreasing in the systolic BP, decreasing in the cardiac output, tachypnea will be there, tachycardia will be there, distension of the jugular veins will be there. So that will be the clinical features, same as the tension pneumothorax as far as cardiac tamponade is concerned. So what is happening over here is that rapid accumulation. Okay, rapid accumulation is happening. Okay, rapid accumulation of blood in the pericardial space, in the pericardial space, right? So rapid accumulation of blood is happening in the pericardial space, and obviously how we'll be treating this patient, we need to actually evacuate this extra amount of blood from the pericardial cavity. Now usually in the clinical feature section we are talking about the Beck's triad. In the clinical features we are talking about the Beck's triad in these patients, and in the Beck's triad what we are seeing is, three important components. $1 million question, that what is happening in the backstride, what are the components of the backstride, what is not seen in the backstride. These kind of questions are coming very frequently. So if you talk about the backstride, one component is hypotension, that is decrease in BP. Okay, another component is muffled heart sounds, muffled heart sounds, and the another component is the distension of the neck veins, that is the increased JVP, so distended neck veins. Okay, so this is the triad of the cardiac tamponade. Okay, and usually by the help of EFAST, that is the extended focused assessment sonography in trauma, by the help of EFAST, also I told you that by keeping the probe in the epigastric region also, we can actually check for the pericardial tamponade, right? Okay, or cardiac tamponade. So as far as management is concerned, we are having again two options. One is the emergency management and another one is the definitive management. Okay, in the emergency management we are talking about the needle pericardiocentesis. Needle pericardiocentesis, and in the definitive management we are talking about the emergency thoracotomy. Okay, so what we are doing in the needle pericardiocentesis, let me tell you by the help of diagram only. Here you can look what is happening. We are actually going through at an angle of 45 degree, okay, in this particular direction toward the left shoulder. Okay, so by going in this direction into the xiphoid process, okay, in this direction by going into the xiphoid process at the angle of 45 degree, we can get into the pericardial cavity, and we can actually evacuate some amount of extra blood from the pericardial cavity. Even by aspiration of about 10 cc of blood will drastically change the hemodynamic profile of the patient. Okay, so that is about the needle pericardiocentesis. Okay, here you can see the blood is getting filled up in the pericardial cavity and causing the tamponade effect, so cardiac tamponade. Okay, compressing the heart from outside. Here you can see the hypoechoic area in the pericardial sac. Okay, that is showing you what in the echo, that is showing you what, that is the cardiac tamponade. Okay, so hypoechoic region in the pericardial cavity shows you the cardiac tamponade. Obviously needle pericardiocentesis, which I showed you in this diagram also. Yeah, so this is the needle pericardiocentesis. So here also we are doing this procedure under the guidance of echo. Okay, pericardiocentesis, we are doing this procedure under the guidance of echo, obviously. Okay, and as we are inserting into the pericardial cavity, we'll try to drain some extra amount of blood from there. Okay, so that was about the cardiac tamponade. Now I'm moving on to the next one, that is the okay, mega singular chest x-ray of hemothorax. Yeah, I'm saying if the hemothorax patient will be getting chest x-ray. Okay, usually these kind of injuries we don't have the time for the chest x-ray, that is very true. Okay, we need to actually clinically diagnosing them, but in case after stabilizing the patient you are doing the chest x-ray of this patient, you will be knowing that the patient is having the air fluid level. And by the way, let me show you the air fluid level as well, as I forgot. Yeah, this is the picture of hemothorax, and what you can see is air is black in the x-ray, and whatever fluid you are seeing, it might be pus, it might be clear fluid, it might be turbid fluid, it might be blood. Okay, whatever fluid you are seeing on the x-ray, that is looking white in nature, white in color. So here you can see the fluid is actually filling up in this area. Okay, fine. So what we can see is that here in this area you might see some air, but below that you can't see anything, right? So this was the air fluid level I was talking about. Okay, so here you will be seeing the air and here you will be seeing the fluid. So this is called as the air fluid level. Okay, and that is seen where? In the hemothorax or in the hemopneumothorax. Okay, fine. Okay, so I hope that is clear. Now, after the thoracic injury, so we have talked about the basics of trauma, then the head trauma, then the thoracic department, thoracic trauma, and then I'm coming to the abdominal regions now. So we'll be talking about the abdominal injuries now. Okay, so let's talk about the abdominal injuries. Okay, abdominal injuries, or you can say that as abdominal trauma. Okay, so most commonly involved organ in the abdomen trauma is the spleen, guys. It's a very highlighted MCQ that most common overall injured organ is the trauma, right? Then if you talk about the abdominal injuries, here also in the thoracic also I told you that blunt thoracic injuries and the penetrating thoracic injuries. Here also I'm starting like that there could be the blunt abdominal injuries and the penetrating abdominal injuries. So there might be the two types, that one could be the blunt abdominal injuries, and another one could be the penetrating abdominal injuries. So penetrating abdominal injuries, right? So no surprise in that. Penetrating abdominal injuries means somebody stabbed in the abdominal cavity, and you know what can happen. So in these kind of patients, usually they are not hemodynamically stable. So let me just start with the blunt abdominal injury first. So blunt abdominal injuries, okay, what they are saying, blunt abdominal injuries, there could be two scenarios. Same with the penetrating abdominal injuries, there could be the two scenarios. In the blunt abdominal injury, either the patient might be hemodynamically stable, either the patient might be hemodynamically unstable, right? Either the patient might be stable, either the patient might be unstable. In the penetrating abdominal injuries also, either the patient might be stable, either the patient might be unstable. Okay, either the patient might be stable, either the patient might be unstable. Now, for the head trauma patient, we know what is the investigation of choice. For the thoracic injuries, we know what is the investigation of choice. Coming to the abdominal injuries, what is the investigation of choice? So if the blunt abdominal injury patient is coming and the patient is stable actually, then initially we'll be doing the fast so that we get the overall idea where is the injury and where is the blood accumulation happening in the abdominal cavity. So to just get the overall picture, we will be taking the help of initial investigation would be the fast focused assessment sonography in trauma. Okay, so initially we'll take the help of fast. But investigation of choice in these kind of patient would be contrast enhanced CT scan. That would be the investigation of choice for these patients. For unstable patients, either you say initial investigation, either you say investigation of choice, it would be the fast for the hemodynamically unstable patient. For the stable patient, you have time. That's why you can do the CT scan of the patient, okay, as it needs time. But unstable patient, you don't have time. So there is wastage of time sending this patient into the CT scan. The patient might collapse into the CT scan room only. So that's why if you talk about the unstable, okay, fast would be the investigation of choice, or any investigation would be the fast in cases of unstable blunt abdominal injury patients. If you talk about the penetrating abdominal injuries, and if you talk about the stable patient, right? Now we are actually analyzing the patient on the basis of either the patient is having peritonitis or not. So usually the stable patient will not be having the peritonitis. What is peritonitis? What is peritonitis actually? Yeah, so the accumulation of any kind of fluid is happening in the peritoneal cavity, and due to that inflammation is happening of the peritoneal cavity and the peritoneum. Okay, that is causing the peritonitis. That is the peritonitis. In the unstable patient, usually peritonitis is there. In the unstable patient, usually peritonitis is present, right? So if the peritonitis is not present, whatever injury you are seeing over there, okay, you will just clean it off. Local wound care you will give. Okay, and then you will send this patient for the CECT scan, contrast enhanced CT scan, because now patient is not having peritonitis, the patient is stable. You can send this patient for the CT scan, CECT scan. If you talk about the investigation, if you talk about the patient who is unstable, you can't send this patient for CECT scan. And here the peritonitis is present in this patient. What you will do? You will do the midline laparotomy. Okay, you will do the midline laparotomy. You need to explore the abdominal cavity of these patients, midline laparotomy of these patients. Okay, now this is the overall picture. And by the way, in the penetrating chest injury, whenever they are actually coming up into the trauma unit, okay, whatever they might be having objects inside their abdominal cavity. Okay, in same applies with the thoracic cavity injuries also, that if the knife is in the thoracic cavity, okay, it should be removed in the operation theater only. Otherwise, it should not be removed in the casualty or the emergency room, because it might have some, tamponade effect. It might press onto some vessel. Okay, and if you try to remove it in the casualty or in the emergency room, it might lose that effect, and that particular vessel, okay, might bleed profusely and the patient may die. So in the operation theater, okay, still you can do something. Okay, but in the emergency room, it will be very difficult to save the life of that patient if you will be doing that. So better to take this patient to the operation theater. Let's say the patient came to the trauma unit and having knife inside the abdominal cavity, better to take this patient into the operation theater, and then we'll try to remove it. Okay, fine. Now coming to the next point over here, I told you that overall abdominal injury, if I'm saying that spleen is the most common organ involved. So I'm just talking about the different injuries now. So starting with the spleen injury, as it is very common. So in the abdominal injuries, coming up with the spleen injury. So in the spleen injury, what we are seeing? So some important points. It is the most common overall injured organ. Okay, that we know already. It is the most common organ injured in blunt trauma injuries. Injured in blunt trauma injuries. Okay, these kind of one-liners might be asked in the FMGs and other MCQs examination. Then most common organ involved in children also, it is same. Most common organ involved in children also, it is same. That is the spleen. Very commonly it is involved. Then whenever the floating ribs are getting injured, where is the location of the spleen on? That is the left side. Right side we are having the liver, and the spleen is present on the left side. So here we are having the floating ribs. These are the 9 to 11 ribs, 9, 10 and 11. Whenever these ribs are getting injured or getting fractured, there is very high possibility of injury of the spleen as well. So whenever the floating ribs are getting injured, okay, or the 9 to 11 ribs are getting injured or getting fractured, okay, usually they might lead to the splenic injury. Okay, usually they might lead to the splenic injury, right? Okay, now usually what you can see is that there could be the bluish discoloration in this particular area, that is the left sided lower chest wall. So you might see some bluish discoloration in this particular area. So bruising or bluish discoloration might be seen. Bruising might be seen in the left lower region. Okay, left lower chest wall. Fine. Okay, left lower chest wall. Okay, on the lateral side, obviously that is the location of the spleen. Okay, if the floating ribs are getting injured in that case. Now a very important sign can be elicited in the splenic injuries. Okay, and that is the Kerr sign. Okay, that is the Kerr sign. And what is the Kerr sign actually? What happens is, I will show you as well. Yeah, this is the Kerr sign. What we are seeing over here is that the splenic injury happened. Okay, I will talk about the grades of the splenic injury also. Splenic injury happened. Due to the splenic injury, what happened is that it is actually stimulating. Here we are having the diaphragm. Here we are having the diaphragm. Okay, so it is actually blood is accumulating in this particular area. Blood is accumulating in this particular area due to the bleeding. Okay, and due to that accumulation of the blood, it will irritate the diaphragm. It will irritate the diaphragm, and that will lead to the eliciting pain. That will lead to the eliciting pain, and that will lead to the referred pain. okay, onto the left side shoulder tip. Okay, because obviously the spleen is present on the left side, so referred pain will be seen in the left shoulder tip because of the irritation of the phrenic nerve that is just present near the diaphragm. Okay, fine. So that is called as the Kerr sign. So due to the accumulation of blood, okay, because of the splenic trauma, due to the accumulation of blood near the diaphragm, it will irritate the phrenic nerve that will cause a referred pain at the tip of the left shoulder. That is called as the Kerr sign. Fine. So that is the Kerr sign. Okay, fine. Now, let me just document it as well. That what is the Kerr sign? So Kerr sign basically it is the eliciting pain or referred pain in the eliciting or referred pain in the left shoulder tip, pain in the shoulder tip left shoulder tip due to the accumulation of blood below the diaphragm as a result of splenic trauma, right? I hope you get the idea what is the Kerr sign, right? Okay, then let's talk about the grades of the splenic injury, right? And here you can see the grading of the splenic injury in this particular picture. Wait, let me just show you as well. Okay, yeah, so this is the grading of the splenic injury. Okay, this is the grading of the splenic injury, right? So what we can see is that in the grade 1 we are talking about the hematoma that is less than 10% and laceration that is less than 1 centimeter. Okay, hematoma it is subcapsular, 10 to 50% area is getting involved, and intraparenchymal less than 5 centimeter of the area is involved, and the laceration if you talk about 1 to 3 centimeter depth is seen over there. If you talk about the hematoma that is subcapsular, more than 50% surface area that is actually involved. Okay, intraparenchymal hematoma that is more than 5 centimeter. Okay, it is just more theoretical. Laceration is more than 3 centimeter, parenchymal death. Okay, that is seen in the grade 3. In the grade 4, laceration would be for the major segmental vessels. Okay, and devascularization of major part of the spleen, that is more than 25% of the spleen. Okay, laceration might be seen in the fifth one. Laceration might be seen in the spleen, completely shattered in spleen. Very severe injury to the spleen can cause that. And as far as vascular pattern is seen, it might be getting devascularized, so necrosis might happen. Okay, this is the grading of the splenic injury, right? Now, how will you manage the splenic injury patient? Now, management happens according to the grades of the splenic injury. Management happens according to the grades of the splenic injury. For an example, if there is grade 1 to 2 injury, then what you will do in that case? Okay, if there is grade 1 to 2 injury, what you will do? Look guys, grade 1 to 2, it means usually the patient will be stable. Okay, usually the patient would be stable. In these cases, you will send the patient for CT scan. The investigation of choice was, I told you, that was investigation of choice for the abdominal injuries. Please write in the chat box what is the investigation of choice in the splenic injury patient, that is the abdominal injury part. So if the patient is stable, you would like to send this patient for which scan? That would be which scan, guys? That would be just waiting. That would be the contrast enhanced CT scan, CECT. Okay, that would be the contrast enhanced CT scan. If in okay, and what we'll be doing, we'll be actually looking for this monitoring the splenic injury. If we'll be monitoring the splenic injury, if the grades are actually increasing, for example grade 2 injury was there, and if it is converted into the grade 3 injury, then we need to react accordingly. So what we will be doing in that case, we'll be doing the angioembolization. Even if that fails, then what we will do is that we will be actually going for the surgery option, and that would be the splenography. That would be the splenography. Okay. Now, if the injury, I will come to the grade 3 later on. If the injury will be grade 4 to grade 5, let's say grade 4 to grade 5, in that case the patient might be unstable. Probably the patient would be unstable usually, so you can't send this patient for the CCT scan. Now in this case, investigation of choice would be the fast, because you can't send this patient for CCT scan. Investigation of choice would be the fast, and usually in this case you will be doing the splenectomy, because it is bleeding profusely and usually it is lacerated very heavily. The blood supply is gone in most of the cases, so in this case splenectomy is the better option. Okay. In the grade 3 injuries, if the patient is stable, you will follow this pathway. If the patient is unstable, you will treat according to grade 4 or 5 injury, right? So that is the case of uh, you know uh, management of the spleen trauma. What is splenography? In this case, we are preserving the spleen preserving surgery. Okay. And splenectomy means we are removing the spleen at all. Okay. So liver trauma, spleen is done, liver is on the right side, liver trauma. So in case of liver trauma, okay, it is also very important. Okay. In the liver trauma, grades are very important. Okay. The grades, if you will talk about, because according to the grades we are actually treating the patient. Okay. So grade 1, 2, 3. Okay. Grade 1, hematoma less than 10% and laceration less than 1 centimeter. So gradually it will be increasing, like the splenic injury. 10 to 50% surface area is involved over here, and less than 10 centimeter interperitoneal area will be involved over here in the second one. Okay. Now laceration would be 1 to 3 centimeter parenchymal depth and less than 10 centimeter in length laceration in the second one. Hematoma subcapsular more than 50% and intraparenchymal hematoma more than 10 centimeter. Okay. So in the fourth one, 25 to 75% of the hepatic lobe is gone, and in the fifth one, hepatic avulsion is seen. Now, if you're talking about grade 1 to 3, okay, grade 1 to 3, usually patients are stable and we will be managing them conservatively. If you talk about the grade 4 to 6, okay, grade 4 to 6, what we'll be doing basically, we are having some options. What are these options? Okay, so the treatment over here, okay, I would be rather writing over here. Okay, so grading is done. How to do the management according to the grading part? So management according to the grading part. So grade 1 to 3, 1 to 3. Okay, in the grade 1 to 3, then what you will be doing is basically conservative management will be doing, because this patient will be stable. Conservative management. Again, you can send this patient for the CCT scan, and accordingly you will be managing them conservatively. In the grade 4 to 6 patient, either you can do the bimanual compression and you can stop the bleed. Okay, either you can do the Pringle maneuver. Now Pringle maneuver is asked very commonly. Okay, so Pringle maneuver, let me show you. What we are doing, we are actually clamping the hepatoduodenal ligament. What you are seeing over here, we are clamping the hepatoduodenal ligament in order to stop the blood from the hepatic artery injury or the portal vein injury. Okay, but we can't clamp it more than 15 to 20 minutes, as it can cause the necrosis of this particular segment. So we'll clamp this area for about 15 to 20 minutes, and then we'll be checking for the bleeding from that side. Okay, so to stop the bleed from these areas, we are actually clamping the hepatoduodenal ligament, and that is usually called as the Pringle's maneuver. Okay, so this is the Pringle maneuver. Okay, this is the Pringle maneuver, right? This is the Pringle maneuver. Okay, so this is about the liver injury. Okay, now at last I'm coming to the mesenteric injury. So in the mesenteric injury, what we are seeing, usually the mesentery is getting involved in the abdominal cavity. Okay, mesenteric injuries, right? Usually the mesentery is getting involved, and most commonly it happens due to the seat belts. Now how the seat belts can cause the mesenteric injuries, because look, whenever the patient is getting injured in the car accident, let's say if the patient is having seat belt, the patient will be going in the forward direction, right? But seat belt will try to push it in the backward direction, push the patient into the backward direction. Meanwhile, the mesentery will be getting compressed between the seat belt and the vertebral column of the patient. So mesentery will be getting compressed, and due to that, mesentery injury might be seen in the patient, right? So, so mesenteric injury might be seen in the patient. Now, so most commonly it is seen in what cases? Most commonly it is seen due to seat belt syndrome. Simply naming it syndrome because seat belt can cause the compression of the mesentery. That's why we are calling that as seat belt syndrome. So in the seat belt syndrome, basically there could be the longitudinal tear and there could be the transverse tear. Okay, there could be the longitudinal tear and there could be the transverse tear. If there is longitudinal tear, usually then only the bowels are getting decreased or compromised blood supply. Due to that, bowel ischemia will be seen. And in the transverse blood supply, okay, so the longitudinally the tear might be there, longitudinal tear might be there, or the transverse tear might be there, transverse tear might be there. Okay, so in the longitudinal tear, if you are talking about, then bowel ischemia is seen. Okay, only the blood supply is getting compromised, bowel ischemia is seen. And here we are talking about the bowel necrosis, bowel necrosis. So here obviously what we need to do, we need to resect that part of resection, and anastomosis will be done. Anastomosis will be done as a treatment for transverse tear mesenteric injury, and for the longitudinal injury we just need to do the repair of the tear. Just need to do the repair of the tear, right? That would be the management, right? So that is basically the mesenteric injuries. Okay, so like that we can talk about the duodenal injuries also. In the duodenal injuries, one might talk about the duodenal hematoma and the duodenal perforation. Okay, in the duodenal hematoma, we are actually keeping the patient NPO, that is nil per os. We are not allowing the patient to eat anything from the mouth in the duodenal hematoma patient. In the duodenal perforation patients, usually we are actually doing one procedure, that is the Graham's patch Graham patch repair or the omental patch repair. Okay, so that is about the duodenal injuries. So just documenting it, that we are having the duodenal injuries, right? In the duodenal injuries, we are having the duodenal hematoma, and the duodenal uh, perforation. Duodenal perforation. Now, in the duodenal hematoma, if we talk about here, we need to actually keep the patient NPO, and in the duodenal perforation patient, we need to actually repair. And what kind of repair we are doing, because perforating, so in this case we are doing the omental patch repair, or it is also called as Graham's patch repair. It is also called as the Graham's patch repair. Okay, and that has been asked a number of times as well. Okay, so in the duodenal injuries, okay, which kind of repair is done in the duodenal perforation cases? That is the omental patch repair or the Graham's patch repair. Okay, so was it about the mesenteric injuries also, and we are done with the abdominal trauma as well. Okay, so at last, what we have talked about in the today's session. So we had started with the trauma, where we had talked about how to transport the patient, and then we had talked about the triage, that how we are dealing with the how we are dealing with the injuries of the patient, like how we are sorting out the patient, that according to the severity of the injury. Then after that, we had a talk about the uh, basics of trauma, like ATLS guidelines, that airways, breathing, circulation, and the disability part. In the disability, very important, we had to talk about the GCS, that is the Glasgow Coma score, or I would say Glasgow Coma scale, okay, of that patient. Then we had a talk about the head trauma patient, where we had to talk about the anterior uh, skull base fracture and the middle cranial fossa and the posterior cranial fossa fractures. Then we had a talk about intraparenchymal hemorrhages, extradural, subdural, and the subarachnoid hemorrhages. Then we had to talk about thoracic injuries. In the thoracic injuries, we had to talk about the blunt and penetrating, thoracic injuries. Then we had to talk about the pneumothorax, hemothorax, cardiac tamponade. Okay, all of these aspects. Then in the abdominal injuries, at last, we had to talk about the splenic injuries, liver trauma injuries, mesenteric injuries, duodenal injuries at last, right? So I hope you enjoyed the session thoroughly, and I would like to know the feedbacks from you, that how the session was, and I hope you enjoyed the session. So thank you so much for joining this one, and we'll be meeting you guys tomorrow in the burns section. Tomorrow I'll be discussing the burns with you guys, and we'll be learning over there what are the burns and what are the criteria to diagnose the burns, and different kinds of formulae for the burns and all, and about the treatment modalities. All right. So I will see you there tomorrow in the burn section, sharp 7 p.m. Right. Thank you.